Hi, I'm Adesh Kadambi, an MASc candidate at the University of Toronto.
And I'm Senan Ebrahim, a PhD and MD candidate at Harvard Medical School.
And we'll be discussing our findings on the relationship between patient demographics, including gender and ethnicity, and the patient treatment and outcomes in the ICU.
One key outcome measure in critical care units is the mortality rate. Studies that have looked at correlations of gender with hospital mortality have come to conflicting conclusions. In one 2-year retrospective analysis of patients admitted to a mixed medical surgical ICU, women had higher mortality rates than men. But in another study evaluating differences in 28-day inpatient mortality between male and female trauma patients, they reached the opposite conclusion. Even when the scope is narrowed to studies that follow mortality rates between ICU patients with severe sepsis or septic shock, large cohort studies tend to reach indeterminate conclusions.
Interestingly enough, several studies have found decreased efficacy of pain management among minority populations across several health settings. This could be due to a number of reasons, including differences in pain perception, cultural differences with respect to pain tolerance, or even the physician's own ethnicity.
In this study, we aim to model how pain management decisions are made in the complex and highly acute ICU environment. Specifically, we want to understand how ethnicity and gender relate to pain management decisions and patient outcomes.
The eICU dataset is among the most extensive and granular ICU datasets available to the public. This dataset's widespread aggregation was enabled by a centralized, multi-center tele-ICU program where this data was used for real-time patient monitoring by a remote clinical team. Studying these questions through the tele-ICU data is of particular interest due to the scale and diversity of the database, which can provide a platform for drawing insights and creating clinical decision support tools and guidelines across larger populations.
Our objective was to mine the eICU dataset rigorously to answer key focused questions about associations with and predictions of mortality and analgesia in the ED and ICU at hospitals around the country. Briefly, we conducted extensive statistical tests that were tailor-made to the research question, mostly chi-squared tests since we were dealing with categorical data for both mortality rates and pain medication administration. We Bonferroni corrected our alpha threshold for significance due to multiple statistical testing in this study. We used IPython notebooks for all of our analyses, which are all available online at our GitHub. We found that all-cause mortality showed no statistically significant difference between male and female admissions in the ED-ICU population overall. All-cause mortality rates for ED-ICU trauma patients were significantly different between female and male patients, with a 3.8% mortality rate for female trauma patients and a 5.6% mortality rate for male trauma patients, which was significant as measured by a chi-squared test. For MI patients, we found that the opposite effect was significant by chi-squared test, with a mortality rate of 4.8% for females and 3.6% for males. All-cause mortality rates for ED-ICU sepsis patients showed no significant differences. We chose to focus on the finding of significantly higher mortality for male trauma patients than female trauma patients, with past studies supporting this finding hypothesizing that differences in coagulability between genders may be contributory. For trauma patients, mortality rates were not significantly different by gender within each PTI-NR bin, validated by a Breslow day test with a PTI-NR thresholded at 2. Chi-squared tests for each of the male and female trauma patient mortality rates by PTI-NR, similarly thresholded at 2, were significantly higher for higher PTI-NR values. A similar result was found when we binned by Apache 4A scores. Taking a look at the normalized distribution of PTI-NR for male and female trauma patients, male patients did not have significantly higher mean PTI-NR lab values as determined by a t-test. Our analyses suggest that female trauma patients, in fact, do not have significantly different PTI-NR values from male patients, though as mentioned on the last slide, a higher PTI-NR value correlates with worse outcomes for both genders. This finding contrasts with previous ones using an order of magnitude fewer patients, showing male trauma patients exhibiting relatively hypocoagulable states relative to female patients in correlation with higher mortality.
Shifting our focus to pain management, we broadened our patient population to include all ICU admissions rather than solely ED-ICU patients due to the significant missing data challenge for the administration of analgesic medications. In this figure, we notice a significantly lower proportion of patients of Native American ethnicity receiving pain meds as compared to other ethnicity, a finding that's true of both genders. However, taking a look at the average self-reported pain scores on a scale of 1 to 10 by ethnicity, we noticed that Native American patients who did not receive pain medications had significantly higher pain scores than ICU patients of other ethnicities. our dataset confirms lower analgesic administration for Native American patients, even at relatively higher levels of reported pain nationally in the ICU, meriting closer examination. Notably, however, no such correlation was observed for African American and Hispanic American patients in the ICUs around the country, despite these correlations being reported in past studies of analgesic use in the ED throughout the past 3 decades. Aside from basic patient information including age, gender, height, and weight, as well as hospital and unit admission information, here are some of the features we included for each patient subset in our study. For data preprocessing, qualitative features were one-hot encoded and quantitative features were scaled before splitting the data into training and testing sets. We then applied a gradient-boosted tree classifier and plotted the ROC. Due to the algorithmic nature of gradient boosting, we then used SHAP values to show how much each feature contributes to the target variable to better interpret our model. Our trauma mortality model reports an AUC of 0.73. On the right, we see the SHAP values mentioned previously for the top 15 most predictive features for trauma mortality, as well as their impact on the model's output. Some of these features include age, ICU stay duration, metabolic panels, and blood count values. Similarly, for our analgesic use model, we achieved an AUC of 0.75. Referring once again to the SHAP value, some of the most predictive features for analgesic use include age, maximum pain score, and potentially painful procedures like ventilator wean, as well as specific regional and hospital identifying variables.
In this table, you can see our predictive models at work for both the trauma mortality outcomes and ICU analgesia administration based on patient profile. Patient 1T and patient 1A represent actual patients in the dataset, while patients 2T and 2A represent model patients with only their gender or ethnicity changed. We see that patients with identical trauma characteristics exhibit conflicting predicted mortalities based on their gender, and patients with identical profiles in the analgesic use model have different predicted outcomes based simply on their ethnicity. In summary, our analysis of the eICU dataset rendered several clear conclusions from our statistical analyses and modeling. Firstly, ethnicity and gender both have significant clinical correlations with treatments or outcomes in the ED and ICU. Secondly, mortality rates were clearly lower for female patients in the ED-ICU trauma population than male patients. And finally, analgesia administration for ICU patients is significantly lower for Native American patients around the country, despite having higher pain scores. The clinical implications of these differences in treatments and outcomes are significant. We would like to thank the MIT Lab for Computational Physiology and Philips ERI for making available this rich data set for public analysis, and we will continue to analyze it rigorously to assess the state of clinical care across the country with an eye to equitable treatment and improved outcomes for patients of all backgrounds.